Hello, my name is Robert Hendel. I'm currently the Chief of Cardiology at the Tulane School of Medicine and the Director of the Tulane University Heart and Vascular Institute. I've been involved with prior authorization for more than 15 years, initially when it first surfaced, where I served on the Appropriate Use Criteria Task Force, and later as a trustee. I have now been a member of the Board of Trustees for 4 years. Prior authorization was initially instituted by payers and radiology benefits managers in an attempt to try to control the escalating cost of healthcare. However, it's an indiscriminate volume reduction that requires a great deal of work from physicians and their offices to go through the process of gaining such approval. These barriers actually impact on whether or not the patient has access to much needed tests and procedures, and takes the decision-making often out of the hands of the clinician and into the hands of the insurance company. The impact of prior authorization results in a great deal of extra work and a lot of time and expense from a provider's office, meaning the hospital or even the staff of the physician's office. It also sometimes engages the physician in time that they must spend actually justifying what they thought was in the best interest of the patient. Furthermore, it impacts on the patient because now they ask, why are you being questioned about your decisions? Did you order something wrong? And therefore it's interfering with the provider-patient relationship. Ideally, we as a specialty in cardiovascular disease need to eliminate the need for prior authorization. We must order appropriate tests and procedures and follow guidelines and appropriate use criteria which optimize our utility of cardiovascular technology. We certainly want to be aware of the cost-effectiveness of procedures, but provide optimal care. Unfortunately, prior authorization gets in the way. We want to get rid of it, but we have some tools to help us. We have a number of clinical decision support instruments that are there, and obviously a suite of documents called appropriate use criteria, which really should be guiding us in how we use our technologies. Unfortunately, prior authorization has gotten in the way. The long and the short of it is we need to figure out ways to get rid of it, or if we have it, at least have it based in concrete evidence such as provided by guidelines and appropriate use criteria.